Are we good to do that? Okay, great. Good evening, good morning, good afternoon, based on wherever in the world you're joining us from. Welcome to the 14th webinar, Nepal Mental Health Research Webinar Series Go, which is on adaptation of interventions developed in the Global South in the Global North. Our speaker is Dr. Manaswi Sangraula, who will be diving deeper into this topic with us in a short while. A couple of quick housekeeping items before then. सबैजनालाई म जानकारी गराउन चाहन्छु कि हाम्रो यो वेबिनार रेकर्ड भइरहेको छ. I hope that everybody agrees to this. यो गर्ने मुख्य कारण चाहिँ we will be sending out webinar materials to everybody at the end of this webinar, including the presentation and our webinar recording and other materials. So we hope we have your consent to record this. And also, in order to not flood the emails of our network members, we are only sending webinar materials to those who register. यदि तपाईहरुले अहिलेसम्म रेजिस्टर गरिसक्नु भएको छैन भने पनि इमेलमा अनि हाम्रो सोशल मिडिया पेजेसमा रेजिस्ट्रेसन फर्म छ, प्लिज रेजिस्टर गर्नुहोला अनि हामीले तपाईहरुलाई वेबिनार मटेरियल्सहरु वेबिनार सकिसकेपछि पठाउन सक्छौं. The structure of our webinar will be, we will have around 15 minutes for the presentation, for the core topic. त्यसपछि लगभग 10-15 minutes question answers, which can be based on the presentation or based on your experiences. So basically, you can provide comments and ask questions about the content of the webinar. त्यसपछि चाहिँ, as we've done in the past few months, we will be moving into breakout rooms. हामीसँग आज 3वटा breakout rooms हुन्छ, in which we will go in and discuss some discussion questions that has been provided to us by हाम्रो speaker. This will be a forum for in-depth discussions, so I encourage everybody to please remain and be a part of it, as it is a very good way of extending our peer-based knowledge system. So please do stay. And अर्को एउटा important कुरा चाहिँ हामीले feedback formहरु पनि prepare गरेका छौं. As regular participants of our webinar know, we always share feedback forms so that we know how to make our webinars better and how to learn more from you, and also to bring out webinars that you all are interested in. So webinar ko beach tira ani end tira pani I'll be posting the feedback form in the chat box, and at the same time at the end of the webinar we will be sending out the feedback forms to you. So त्यतिखेर पनि तपाईहरुले हामीलाई आफ्नो feedback पठाउन सक्नुहुन्छ. At the same time, chat box को कुरा गर्दाखेरि हाम्रो presentation को end भइसकेपछि जुन हाम्रो question answer session हुन्छ, त्यसको लागि पनि तपाईहरुले chat box मा आफ्नो questions हरु राख्न सक्नुहुन्छ, अथवा हाम्रो presentation सकिसकेपछि चाहिँ तपाईहरुले आफ्नो hand raise गरेर questions हरु सोध्न सक्नुहुन्छ. हामी usually presentation मा चाहिँ interruptions हरु entertain गर्दैनौं. So त्यति भयो हाम्रो वेबिनार को कुरा. हाम्रो डिस्कसन सेसनमा को-मोडरेट गर्नको लागि हामीसँग हाम्रो सधैँको साथी हुनुहुन्छ विनिता जी. Vinita ji is a junior researcher at TPO Nepal, and she will also be a co-moderator with us during the breakout sessions. A small deviation from hamro webinar, hamro every third week of English month ma webinar huncha bhanne tapaile थाहा पाइसक्नु भएको छ. हाम्रो यहाँ सोशल मिडिया को ह्यान्डलहरु छ, त्यो हामीले वेबिनार को स्लाइड शेयर गर्दाखेरि पनि तपाई देख्न सक्नुहुन्छ. तर दुईटा शॉर्ट इम्पोर्टेन्ट अनाउन्समेन्ट्स. हामीले नेपाल मेन्टल हेल्थ रिसर्च नेटवर्क रिसर्च मिनी ग्रान्ट 2023 को लागि कल फर एप्लिकेसन गरेको छौं. त्यसको लागि केही एलिजिबिलिटी क्राइटेरिया छ जसकोमा म एकैछिनमा आउँछु. तर ग्रान्टको रेसिपिएन्टले $2500 अवार्डेड हुन्छ उहाँको एउटा स्टडीको लागि र डेडिकेटेड रिसर्च मेन्टरशिप पाउनुहुन्छ. तर उहाँले आफ्नो स्टडी कम्प्लिट गर्नुपर्छ र म्यानुस्क्रिप्ट पनि एउटा पियर रिभ्युड जर्नलमा within 18 months of receiving the grant उहाँले सबमिट गर्नुपर्ने हुन्छ. डेडलाइन चाहिँ December 15th हो. यसको इन्फर्मेसन हाम्रो ट्विटरको पेजमा, फेसबुक पेज, इन्स्टाग्राम पेजमा छ. साथसाथै तपाईहरुले हामीलाई इमेल गरेर पनि अझ इन्फर्मेसन लिन सक्नुहुन्छ. एलिजिबिलिटी क्राइटेरियामा तपाईहरुले मास्टर्स लेभल पढिसकेको हुनुपर्छ, or currently be enrolled हुनुपर्छ मास्टर्स डिग्रीमा. पहिले पनि रिसर्च मेथड्समा केही कोर्स वर्क गरिसकेको हुनुपर्छ इट इज एन एडभान्टेज यदि प्रायर एक्सपिरियन्स छ मेन्टल र बिहेभियरल हेल्थ रिसर्चमा नेपालको सिटिजन हुनुपर्छ र साथसाथमा प्रायोरिटी चाहिँ people with lived experiences of mental health conditions, female and gender minorities, early career researchers, अनि जुन हामीले ग्लोबल मेन्टल हेल्थ असेसमेन्ट एन्ड मेजरमेन्ट ट्रेनिङ 2022 अर्गनाइज गरेको थियौँ केही महिना अगाडि त्यसको पार्टिसिपेन्ट्स र यो नेटवर्कको मेम्बर्सहरूलाई चाहिँ प्रायोरिटी दिनेछ फर फर्दर इन्फर्मेसन यु क्यान गो टु आवर सोसियल मिडिया पेजेस र साथसाथमा we also have a grant writing workshop associated. There is a grant writing workshop and an in-person networking event जुन चाहिँ TPO नेपालको अफिसमा हुन्छ बालबाटार काठमाडौँमा छ जुन TPO नेपाल र जर्ज वाशिङटन युनिभर्सिटीको फेसिलिटेटर्सहरूले त्यहाँ फेसिलिटेट गर्नुहुन्छ डिसेम्बर 2nd 2022 मा छ 9 बजेदेखि 4 बजेसम्म there are no fees or anything however it is very much first come first serve भइरहेको छ त्यसले गर्दाखेरि छिटो अप्लाई गर्नु होला again priorities will be given to people with lived experiences and representatives from minority groups र for further information please go ahead हाम्रो social media को pages मा हेर्नु होला केही questions छ भने तपाईले chat मा पनि राख्न सक्नुहुन्छ with that I request Professor Brandon Fort, who is from George Washington University, to please introduce our speaker and get our webinar started.
Thanks so much, Ritika. So I'm delighted today to introduce a colleague and friend, Dr. Manasvi Sangraula. So she currently works as a postdoctoral researcher at the Trauma and Global Mental Health Lab at the New School in New York City. She worked at TPO Nepal from 2016 to 2019 on the adaptation implementation of a randomized controlled trial testing the feasibility and effectiveness of group problem management plus. She currently works on several studies focusing on implementing mental health interventions in New York City and in Latin America. Within global mental health, Manaswi is especially interested in cultural adaptation of interventions, migration, and community-based participatory research methods. She has completed her master's in public health at Columbia University and her PhD from the University of Amsterdam. So I'm just super excited for today's talk because often our work focuses on particular studies done in Nepal. And often that approach takes things that have been done typically in high-income countries and then says, well, how does this fit or not fit in the context of doing work in Nepal and South Asia? What's so exciting about today's doc and Manaswi's work is that she's taken her groundbreaking research on PM Plus with TPO Nepal that was done in southeastern Nepal and now using that in New York City. So this is a field increasingly referred to as reciprocal learning. So the exchange of processes, not just from global north to global south, but also then what can the global north learn from the global south? With that, let me turn it over to Dr. Sangraula. Thank you so much.
Thank you, Brandon, and hi everyone. Namaste. Mero naam Manasvi Sangraula ho. So as Brandon mentioned, today I'll be talking about PM Plus, जुन चाहिँ नेपालमा adapt र implement भएको थियो, and how we're using that learning from that trial to implement PM Plus right now in a high-income country in US. In New York City. So a brief background. So in the picture in there's a world map and you green ma highlight so that's what is considered global south and red ma global north we identify it. So it's a generalization, but it's more so that global north is often seen as having more resources, more economic resources than global south, and especially in terms of mental health, having more resources and health personnel as well. So often, brief mental health intervention such as PM Plus, global north countries, so PM Plus was developed in World Health Organization, and this was global south countries testing. So not only that, there are tools such as assessment, any process such as custody testing on a randomized controlled trial, or even the adaptation process is often developed in the global north countries and adapted to various contexts in global south. So First, a little bit of background, PM Plusma, though many of you may be familiar. PM Plus is a mental health intervention, brief mental health intervention. 5वटा session हुन्छ अनि PM Plus is considered transdiagnostic, meaning different mental health conditions हरूको लागि चाहिँ PM Plus may be effective or helpful. So individual and group versions चाहिँ धेरै ठाउँमा testing भइसकेको छ, such as in many low and middle income countries such as Kenya, Pakistan, Nepal, Turkey, Colombia. And specifically WHO, they'd say PM Plus has been developed to be adapted for different contexts and different settings. So here you can see some pictures, right hand side ma हामीले नेपालमा adapt गर्दाखेरि PM Plus, some of the pictures that were developed from the adaptation process and used in the PM Plus randomized control trial. So first of all, हाम्रो adaptation process नेपालमा चाहिँ कस्तो खालको थियो. So हाम्रो कोही team members हरू पनि यो project को यहाँ call मा हुनुहुन्छ. But PM Plus चाहिँ हामीले two places मा implement गरेको थियो. पहिलो चाहिँ सिन्धुलीमा 2016 देखि 2017 मा त्यो चाहिँ feasibility trial थियो. अनि त्यसपछि मोरङमा चाहिँ larger effectiveness trial from 2018 to 2019. अनि यहाँ adaptation process मा चाहिँ just म के highlight we adapted not only content, so PM Plus को 5 sessions मा के content हरू थियो भनेर, तर we also adapted how it was implemented. So कसरी deliver गर्ने participant हरूलाई recruitment कसरी गर्ने, so त्यो सबै कुराहरू पनि हामीले adaptation process मा we thought about as well. So some important learnings, important findings from this process was that visual material, interactive material are extremely important for participants to keep them motivated outside of the 5 sessions and continue the skills. And our main finding, it was really important to involve stakeholders or people in the community. So to get feedback from participants or participants out of a family or local community leaders, feedback एकदमै important throughout adaptation process पनि अनि त्यसपछि throughout implementation process पनि भनेर एउटा चाहिँ key finding थियो हाम्रो. So on the flip side, mental health care in high income countries, oftentimes high income countries, we think that, there are more resources in high income countries and mental health care is better. And however, it is unfairly distributed over the population. So high income countries such as the US, treatment gap. So usually people that are Black, Indigenous people, immigrant people, low-income people, and then non-white communities especially lack equal access to mental health care. It's sometimes extremely expensive and not covered by insurance, US ma, stigma around mental health, availability, so wait times that's quite long. And you can also see here in the statistic that there's a lack of diversity in the mental health workforce. So though non-white people in the US have higher mental health needs than white participants as part of this survey, workforce only 16% of the psychology workforce is non-white. So quite a culturally competent care for minority communities. And so since the pandemic, high-income countries such as the US, more and more times you gap recognize task sharing intervention it might be really helpful to increase access to mental health care things like PM Plus implement So a few examples, UK PM Plus for asylum seekers, refugees, Netherlands refugee youth I'm going to talk about New York City. So New York City we are now implementing PM Plus with communities that are most affected by the pandemic, and starting from 2020 to ongoing So to give you a little bit of background, New York City PM Plus trial, it's called Recoup. It's a cluster randomized control trial. It's currently ongoing. community-based organizations that provide services, just the housing service, food service, services for people that are unemployed. उहाँहरूको staffको लागि चाहिँ PM Plus training दिने, and then they deliver PM Plus to their clients. So we think that, you know, they already are seeing clients for different services, so it would be a good place for them to deliver PM Plus. So you'd say हाम्रो team हो, and you can see we had a recent team meeting अनि हामी New York City मा चाहिँ when we were doing field work and visiting different community-based organizations on how to best implement PM Plus. So I'm going to give you just a few examples. PM Plus go Nepal go learning, but what we took from that learning and that adaptation process and how we're applying it to New York City ko context ma. So the first example, just the overall process in terms of adaptation. So you can see ki yo Nepal ko process theo ani yo चाहिँ US ma हामीले गरिरहेको छौं हैन. You can see that it's very similar in lots of ways. And the main finding पनि हामीले New York City मा apply गरिरहेका छौं. जस्तो हाम्रो एउटा main finding चाहिँ in Nepal to really involve the community in the adaptation and implementation process. So त्यो गर्नको लागि चाहिँ हामीले New York City मा एउटा community advisory group भनेर form गरेको छौं. So the community advisory group चाहिँ they're people from their staff members from different community based organizations. अनि उहाँहरुलाई चाहिँ they really know the needs of communityहरुलाई चाहिँ mental health care कस्तो कस्तो खालको चाहिन्छ भनेर. So we regularly try to get feedback from them and have meetings to get their feedback about the things that we're adapting for PM Plus as well. Ani Nepalma, through the adaptation process, one of the main findings was practice sessionहरु चाहिँ एकदमै important छ. Practice roundहरु जति PM Plus trainee or PM Plus helpers, facilitators practice भयो त्यति राम्रो भन्ने एउटा main finding थियो. So in the US हामीले practice rounds or practice sessions मा पनि एकदमै focus गरिरहेका छौं. So the trainees उहाँहरुले चाहिँ एकदमै practice मा पनि धेरै focus गर्नुहुन्छ. So next example, and you'd say my favorite example, you'd say the interactive materials. So हामीले नेपालमा चाहिँ we created some interactive materials, जुन चाहिँ tension toolkit, mostly developed by Renasaji Pragati. I think they're on the call right now. तर यो tension toolkit चाहिँ खास गरी के हो भने PM Plus को each session भइसकेपछि चाहिँ to give the participants these tools अनि उहाँहरुले चाहिँ outside of the 5 sessions चाहिँ practice गरिराख्नुहुन्छ भनेर हो. अनि त्यस्तै गरिकन हामीले US मा चाहिँ we made something called a PM Plus workbook. अनि त्यो PM Plus workbook is very similar to tension toolkit, नाम अलिकति different भए पनि तर each strategy मा focus गरेको हुन्छ, and it's almost your workbook so that participants can use it outside of the sessions and can continue practice PM Plus in their homes as well. So अहिले यो चाहिँ हामीले बनाइसकेको छैनौं, but it's kind of an ongoing process that we're getting feedback from. अनि अर्को example in adapting tools, हामीले यो reducing tension checklist or RTC नेपालमा बनाएको थियौं especially for PM Plus to see PM Plus skillsहरु participants हरुले कतिकै use गर्नुभएको छ कि छैन भनेर. So त्यही त्यो reducing tension checklist, you'll see Nepali version यहाँ छ, and त्यसपछि we translated it to English for use in New York City. अनि अलिकति हामीले change पनि गरेको छौं to fit the New York City context. So instead of, for example, Nepali version ma we family and friends साथी परिवारहरुको धेरै कुरा हुन्छ, but in the US context we changed it to others किनभने कोही community ma they may not have friends or family, so we wanted to make it broad and generalized. अनि you're reducing the tension checklist Nepali version ma चाहिँ there's somewhat of a focus on housework or घरको कामको लागि समस्या कतिको हुन्छ भन्ने त्यो क्वेशनहरु पनि छ, but त्यो चाहिँ अलिकति हामीले US version को लागि त्यो change गरेको छौं because the context is अलिकति different त्यो कुराहरुमा. हामीले training पनि change गरेको छौं from Nepal version to fit the US. So यहाँ picture हेर्नु भयो भने हाम्रो उहाँहरु चाहिँ CPSW or PM Plus facilitator मोरङमा. So हामीले first यो PM Plus training चाहिँ नेपालमा for 2 weeks every single day भएको थियो, तर US मा चाहिँ that's not really possible किनभने मान्छेहरुको धेरैको full time job हुन्छ, especially those that work in community organization. So हामीले चाहिँ त्यो change गरेर training चाहिँ अनलाइन ट्रेनिङ बनाएको छौँ अनि त्यो अनलाइन ट्रेनिङ चाहिँ instead of every day for 2 weeks it's more spread out so in the span of 2 months हामीले one training session per week for 3 hours भनेर चेन्ज गरेको छौँ so it's online training अनि त्यो online training चाहिँ हामीले CBO staff or community based organization staff हरूलाई उहाँहरूलाई चाहिँ ट्रेनिङ दिएको छौँ so because उहाँहरूको चाहिँ full time jobs छ we they're very busy हामीले कति ट्रेनिङ को भित्रको कुराहरू कति कुराहरू चाहिँ modify गर्नु परेको छ to reduce the burden on the trainees. So अर्को एउटा example is the CIDT or Community Informant Detection Tool, which was used for recruitment and identifying people that are best fit for PM+. So यो चाहिँ Nepali version यहाँ छ, you can see a story and a few pictures. So हामीले यो adapt गरेर US version अहिले हामीले currently बनाइराखेको छौँ. So US version मा चाहिँ you can see that this is an example story. We have a few different stories. You can see the story is very different. So this story is about an older man, 73 years old, living in New York City, and difficulties with grief, any difficulties with not having social support. So alikati different बनाएको छौँ to fit the context. अनि हामीले चाहिँ यो adversity or difficult situation plus हामीले यो चाहिँ मनको समस्या भनेर CIDT बनाएको थियौँ, but we have changed it a little bit to identify different types of feelings as well. अनि हामीले यो चाहिँ what we're planning to do is create a version that's a story छ plus यहाँ नेपालको CIDT जस्तै चाहिँ we can use some pictures so we can help the community-based organization staff identify people that are best fit for PM+. So overall, there are a few key lessons from work in LMICs that we can apply to high-income countries. एउटा चाहिँ जस्तो for example in Nepal and other LMIC settings, यो task sharing interventions like PM+ यसको implementationहरू चाहिँ often women and अरू minority groups-हरूले गरिरहेको हुन्छ. So त्यो कुरा चाहिँ New York City-मा पनि it seems to be the same so far. किनभने हाम्रो community-based organizations-हरूमा चाहिँ they're mostly staff-हरू चाहिँ mostly women and mostly non-white people. So we really need to think about strategies such as fair pay and training like pani alikati modify garera to reduce the burden of intervention delivery. त्यो कुराहरू पनि सोच्नु पर्ने छ. अनि अर्को चाहिँ one thing that we've also learned from the work in Nepal is your collaboration and partnership service users, but also community stakeholders सँग चाहिँ एकदमै important हो भनेर. So in New York City हामीले चाहिँ regular feedback from community advisory group, any regular feedback from community-based organization, अनि उहाँहरूको involvement र buy-in increase गर्न चाहिँ हामीले त्यो partnership and collaboration strengthen गर्न processहरू develop गरिरहेका छौँ. And then the other key learning is around shifting away from biomedical model. So in the US and in New York City, oftentimes mental health ko कुरा गर्दाखेरि चाहिँ words like depression, mental health disorders, त्यस्तो wordहरू प्रयोग गरिरहेको हुन्छ. तर त्यो wordहरू चाहिँ एकदमै stigmatizing हुन सक्छ. So in Nepal, for example, हामीले PM+ को कुरा गर्दाखेरि चाहिँ depression, anxiety, त्यस्तो wordsहरू instead of using those words, हामीले मनको समस्या भनेर that's how we talked about PM+. So the same model चाहिँ हामीले US मा we're trying to use to make it less stigmatizing for communities. So these are just a few of the learnings. Any additional challenges we're facing right now, New York City ma implement गर्दाखेरि चाहिँ एउटा चाहिँ training and supervision. So your competency around non-specialists, त्यो enact and other competency measures हरू पनि हामीले in New York City apply गरिरहेछौँ. तर training अनि त्यसपछि त्यो ongoing supervision चाहिँ अलिकति गाह्रो नै हुन्छ किनभने हामीले community based organizations हरूमा full time staff हरूसँग गरिरहेछौँ. So a lot of times they don't have time, too much time for PM plus. So त्यो competency level चाहिँ कसरी maintain गर्ने भन्ने चाहिँ त्यो एउटा challenge भइरहेछ. अनि अर्को challenge चाहिँ हामीले अहिले PM plus training, online training गरिरहेछौँ. Dropout rate चाहिँ अलिकति high नै भएको छ in comparison to how it was in Nepal. And त्यो चाहिँ किनभने I think the community based organization को staffहरु चाहिँ उहाँहरुको organization मा नै काम धेरै भइरहेको हुन्छ. So कहिलेकाहीँ चाहिँ PM plus को training चाहिँ it's an additional 3 hours every week with a lot of homework. So त्यो भएर dropout rate पनि अलिकति high भएको हुन सक्छ. अनि अर्को चाहिँ challenge which we're really learning from is maintaining strong partnerships. So त्यो strong partnerships with implementing organizations सुरुमा मात्रै हैन, throughout adaptation process and throughout implementation is also very important. भन्ने त्यो चाहिँ एउटा additional challenge and additional consideration for adapting and implementing PM+. So references and thank you.
Thank you so much, Manasi. Also, you were right on time, so you get kudos and more points for sticking to our time as well. The floor is open for questions. Please feel free, I repeat myself, please feel free to write your questions in the chat box or raise your hands. Drishti, you were the first person to raise your hand. Please feel free to unmute yourself. Draw tapaiको questions सोध्न सक्नुहुन्छ.
Ritika, sorry, that was a clap, not hand raise. So
Oh, sorry.
I'll give space for other people to ask the questions.
Absolutely. So Hada, was that also a clap? Oh, I see a lot of claps and now I can finally tell. Questions चाहिँ तपाईहरुले नेपालीमा पनि सोध्न सक्नुहुन्छ. Whichever is your language of comfort, please feel free to ask questions using that language. While we're waiting, I will ask a question. Oh, we already have a question from Anna. Were there any issues with licensing or the type of credentials required for people delivering the intervention in New York City?
Yes. So I think that is an issue that has been coming up, and I think we're still figuring out how to work through that. So one issue that has been coming up is that when after participants go through the training for PM+, there's a lot of questions around what they're certified to do. So we don't want them to deliver PM+, just after training to anyone. So we've made it clear that going through the training, that means that they can really deliver PM+ within the context of this research trial and not outside of it. However, I think this is a bigger issue as more and more high-income countries start to take up task sharing interventions to deliver in their contexts, and how the licensing will work around that.
And if I could just add, Manasvi, on that point too, one of the important things that we've made as difficult as possible for ourselves is we're not allowing kind of people that are already licensed to be the primary focus of the task shifting. So if somebody already has like an LCSW or other clinical training, then they're not the primary participants in this, because we want to see how it really works with folks that don't have prior professional licensure.
Great, great. I can see more questions in the chat, but for the time being, Nagendra sir, you raised your hand first. Please feel free to unmute yourself and ask your question.
Thank you, Ritika ji. Manasi ji, thank you so much for such a wonderful presentation. म तपाईलाई नेपालीमै सोध्ने भए है, यो दुईटा मेरो क्विक छ, एउटा त तपाई अलिकति टु अर्ली मेबी हैन, यो चाहिँ पहिलोचोटि तपाईको के अरे ग्लोबल साउथमा सिकेका कुराहरु हैन, ग्लोबल नर्थमा यो चाहिँ गर्दै हुनुहुन्छ हैन, के छ ओभरअल अहिलेसम्मको इम्प्रेसन जस्ट बिकज दिस टु अर्ली हैन, कतिको चाहिँ त्यो एप्लाई भइराखेको होला यहाँको लेसन लर्नहरु नि तपाईको आफ्नो ओन एक्सपिरियन्समा एउटा, अनि मेरो इन्ट्रेस्ट चाहिँ अलिकति बढी सीआईडीटी मा, किनभने यो चाहिँ हामीले पनि यो भन्दा 2 वर्ष अगाडि चाहिँ त्यहाँ एउटा युनिभर्सिटीसँग चाहिँ सीआईडीटी लाई चाहिँ युएस मा स्पेशली भुटनिज रिफ्युजी कम्युनिटीमा र त्यहाँको लोकल कम्युनिटीमा नि कसरी एडप्ट गर्न सकिन्छ भनेर कुरा गरेको थियो तर अब त्यहाँ चाहिँ एकदमै हाई लिट्रेसी रेट भएको हुनाले त्यो चाहिँ त्यति एप्लिकेबल हुँदैन कि भनेर त्यो आइडियालाई हामीले अगाडि बढाएनौँ किनभने यो चाहिँ अलिकति पुवर लिट्रेसी भएको ठाउँमा चाहिँ अरू मान्छेहरूले चाहिँ उनीहरूलाई चाहिँ पठाइदिने त्यो खालको कन्सेप्ट भएको हुनाले गर्दा त्यो सिआइडिटी अहिले तपाईँहरूले युज एडप्ट गर्न खोजेको कुरा चाहिँ कसरी हाउ यु होइन युज इट किनभने मेबी सेल्फ रिपोर्ट कुड बी होइन हुनसक्छ कसैलाई तर अर्को मान्छेले आइडेन्टिफाई गरेर रिफर गर्ने कुरा कतिको एप्लिकेबल हुनसक्छ भनेर
Yeah, good questions, Naganda sir. Your first question say, sorry, के थियो first question? Impression
त्यो
चाहिँ के
तपाईँको
हो
ओभरअल
अहिलेसम्म?
इम्प्रेसनमा नि हामीले यहाँबाट सिकेको कुराहरू न्युयोर्कमा कतिको काम गरिराखेको होला किनभने जहिले पनि हामी उताको कुरा चाहिँ यता एडप्ट गरेर कुरा गर्छौँ होइन त्यो जस्ट your impression only.
Okay, I see. Good question. So हामीले one यो अब randomized control trial मा चाहिँ maybe too early to tell तर यो भन्दा अगाडि चाहिँ हामीले single arm trial गरेको थियौँ 2020 देखि अहिलेसम्म अनि so त्यो single arm trial मा चाहिँ we just had not too many participants तर दुईटा community based organization सँग हामीले त्यो यो implementation गरेको थियौँ हैन अनि खास गरी उहाँहरूलाई चाहिँ धेरै मन पर्यो so both त्यो जसले ट्रेनिङ लिनु भएको हैन they really liked it and त्यसपछि participants-हरुलाई पनि they really found it to be good अनि it was a small trial so results-हरु if definitive effective or ineffective त्यो चाहिँ त्यसमा भन्न सकिदैन the qualitative findings मा चाहिँ जसले PM plus पाउनु भएको थियो उहाँहरुलाई चाहिँ they really saw a lot of benefit I think किनभने especially जो participants हुनुहुन्थ्यो उहाँहरूले चाहिँ many of them पहिले mental health services-हरु यस्तो खालको mental health services-हरु पाउनु भएको थिएन so this was one of their first times receiving mental health service पनि अनि त्यसपछि कति कोही participants-हरु चाहिँ यो mental health service PM plus पाएपछि चाहिँ PM plus जसले deliver गरेको थियो उहाँहरूले चाहिँ अरु सर्भिसहरुमा पनि refer गर्न सक्नुभयो अझै additional support को लागि or अरु खालको अब जस्तो housing or maybe education service हामीले एउटा education organization सँग काम गरेको थियौं so उहाँहरूले link गर्न सक्नुभयो so त्यो I think qualitatively त्यस्तो खालको बेनिफिटहरु चाहिँ अहिलेसम्म देखेको छौं तर I think अब we'll see randomized control trial मा अब कतिको effective चाहिँ हुन्छ कि हुँदैन भनेर I think okay maybe I'll pause there तपाईको के
हैन छैन म CIDT अब तपाईको CIDT को
हुन्छ I think CIDT चाहिँ हामीले अहिले किन एडाप्ट गर्न खोजेको छौं भने हाम्रो रिक्रुटमेन्ट प्रोसेस चाहिँ कस्तो छ भने अहिले जो स्टाफहरु हुनुहुन्छ कम्युनिटी बेस्ड अर्गनाइजेसनहरुमा हैन उहाँहरुले चाहिँ क्लाइन्ट्सहरुलाई रेगुलरली सर्भिसहरु दिइराख्नु भएको हुनुहुन्छ मेबी for employment housing other services हैन so our idea is that उहाँहरुलाई चाहिँ क्लाइन्टहरुको नीडहरु के हो भन्ने चाहिँ they know very well अनि त्यसरी नीडहरु आइडेन्टिफाई गरेपछि then they can refer them to PM plus भनेर सोचेको थियौं so far recruitment भर्खरै सुरु भइराछ हैन but one thing that we're finding is that recruitment चाहिँ challenging यहाँ पनि challenging नै छ भन्ने भइराछ किनभने while they are referring people enrollment जो चाहिँ eligible हुनुहुन्छ उहाँहरु चाहिँ it's not 100% or 50% so हामीलाई चाहिँ के लागिराछ भने यो recruitment process say we need to strengthen so you CIDT मा चाहिँ story अनि त्यसपछि यो visuals हरु राख्यो भने स्टाफहरुलाई चाहिँ अझै अलिकति हेल्प हुन्छ भन्ने आइडिया अनि यो स्टोरी हरु चाहिँ हामीले जुन चाहिँ इनएक्ट को त्यो एक्टिङ को स्टोरीज हरु चाहिँ एडाप्ट गरेर हामीले CIDT त्यसमा बनाउन खोजिराछौं हैन so we have जस्तो यो मैले जुन स्टोरी देखाएको थिए प्रेजेन्टेसनमा it's of older 73-year-old man हैन हाम्रो एउटा community based organization they serve senior citizens अनि अलिकति relatable खालको स्टोरी बनाउनको लागि चाहिँ हामीले त्यसरी गरेको छौं but we will see कतिको रिक्रुटमेन्ट को लागि र केस डिटेक्सन को लागि चाहिँ कतिको इफेक्टिभ हुन्छ भन्ने चाहिँ we'll have to see
sorry probably we don't have time तर मेरो तपाईको मेन क्वेशन चाहिँ what are the like key purpose of using CIDT was it just for detection or maybe for a referral encouraging them to seek service like in one or two words because we are running out of time
I think main अहिले CIDT को लागि चाहिँ for detection and referral into PM Plus for screening.
Thank you.
Thank you. Thank you both. My request to please limit yourself to one question per person for now, because we only have a few more minutes of discussion. After that, we will move into breakout rooms and have deeper discussions in which you can feel free to do more back and forth, because this is so interesting. हामी सबैलाई यसको बारेमा एकदम धेरै सिक्नु छ, तर हामीसँग समय सधैँ चाहिँ अलिक कम छ. Anna, I see your hand is raised as well. Was that a follow-up to your previous question? I'd request you to please keep it short.
Yes, it was just a follow-up, and I can actually follow up with Brandon later if we don't have time. I just was trying to understand how you articulated, we've talked about these barriers with reciprocal learning in high-income countries around licensing and credentialing. And so I was just trying to understand how you articulated what the people who were being trained were doing. Since they're not mental health workers, they're not peers, how you described you are giving new skills to community-based organization staff to help manage problems, or just trying to understand how you articulated in the US where there's all of this credentialing involved.
Yeah, great question. So how we've talked about it so far is to make it clear that they're not psychologists, psychiatrists, therapists, counselors, any of that. And we've used the term PM Plus helper to mean that they're gaining skills specifically in delivering PM Plus. So a lot of the people that we're already working with are coming in with a lot of basic helping skills because they're already used to working with clients. So we're thinking of this training as really focusing on specifically delivering PM Plus, and this training allows them to become a PM Plus helper rather than a counselor or a mental health provider.
Pragaji, I see your hand is raised, but we'll address two questions on the chat, and then we will go ahead and address your question. And after that, we'll be moving on to the breakout rooms. Okay, so one question is, how would this intervention be adapted in a low resource setting in the USA, such as rural communities in the Alabama?
Yeah, good question. I think since Alabama is very different from New York City, I think it would probably look a little bit different in Alabama. I think the kind of strategy of delivering PM Plus or having PM Plus helpers be people from community-based organizations, staff from community-based organization. It is a promising model, while I do think there are some challenges. And I would think that in Alabama and rural communities, if there are community-based organizations or even churches, one of the groups that we've previously worked with is a faith-based organization. So any community-based organizations where the staff are already really knowledgeable about the mental health needs of their community would be a really maybe a potentially great strategy to use as well. So I see that as being applicable in a place like Alabama as well.
Thanks, Manaswi. We have a couple of requests for you to connect. Liana is doing something similar in the UK, and it would be great to connect with her. I'll do the connecting once we're done with the webinar. Another question is, how are you thinking about sustainability following the trial?
Yeah, that's a really great question. So I think a few points in terms of sustainability. One of the partners that we're working with is the mayor's office in New York City, and they have done a lot of work around mental health care and sort of capacity building as well. So including partners from the community at sort of the government level, from the mayor's office to community-based organizations as well. I think that would be a great way of increasing sustainability, just to kind of keep them updated on how things are going and really see them as partners throughout this process as well. And then I know we're running short on time, so I'll stop there.
Thank you. Pragyaji, unmute गरेर आफ्नो question सोधिदिनु होला है.
Thank you, Ritika ji. Thank you, Manaswi, for a nice presentation. मेरो चाहिँ PM Plus नेपालमा भएकोले एज अ पार्ट मेरो अपर्च्युनिटी थियो म त्यसमा इन्गेज हुन पाएको सो जस्ट अ क्युरियोसिटी PM प्लसमा कुन कुन सेटिङहरुमा कुन पपुलेसनमा चाहिँ एडाप्टेड भइसकेको छ भनेर एकदम क्युरियस भयो के लाइक so far I यो वुमेन मेन एडभर्सिटीमा भन्ने त अब नेपालमै भइहाल्यो होइन त्यो बाहेक प्रिजन मैले सुनेको प्रिजन डोमेस्टिक भायोलेन्स प्रेनाटल यस्तो कुन पपुलेसनमा अहिलेसम्म सो फार एडाप्टेड भइसकेको छ
प्रज्ञाजी जस्तो युएसमा कि अरू ठाउँमा पनि
सबै ठाउँमा अहिलेसम्ममा या तपाईँको नलेजमा जे जति छ
Okay. I think मलाई लागेको धेरै जस्तो refugee populations or migrant populations मा पनि धेरै adapt भएको छ, especially women अनि those affected by gender-based violence. I know PM Plus को alcohol module पनि थपेको छ हैन. So I think there's different types of adaptation त्यसमा पनि or emotional processing को extra session हरु पनि थपेको छ. So I think there more and more kind of creative and different methods for different populations.
Thank you.
Great. Thank you for this awesome participation. सबैजनालाई धेरै धेरै धन्यवाद participation को लागि. अब we will move on to our breakout rooms. 6:42 भयो. We will continue with the breakout rooms until 6:55 p.m. So let's say 13 minutes. 13 minutes from now. After that, we will come back to the main room for 5 minutes, in which all our moderators of the groups will present a summary of their group discussions in 1 minute. So we'll cap the discussion at 10 to 13 minutes. Brandon, please feel free to release the breakout rooms.
And we've tried our best to accommodate breakout rooms by language. So.
There are a couple who are unassigned, Brandon. I'll send them to room 4. You can join any room you want, Brandon, as the creator. I'll go to room 2 now.
Oh, I got out of the room by accident. Can I go back there? No.
Yes,
I
and
cannot.
I'm also getting out from the room, and I surprised you are laughing at me. I don't know, I'm going over there.
I was like, yeah, I think, yeah, I think I pressed the button by accident, and then I was kicking out. I said, oh, I was about to ask something. That's okay. You're mute.
Sorry, thank you so much. For everybody who feels like their questions were not answered, feel free to write to us at the MHRN network. We will try and sort of like create some buzz in Twitter, etc. for those questions. Yep, everybody's coming back. Great. I can see from everyone's faces
Lisa,
that
can
we have.
you send this record to us, or what is it? Can you send us this record?
We will send the recording to everybody. Please register in the link so that we are able to send you the recordings in your email address. Great. Okay, it seems like everybody had extremely interesting discussions. Can I ask all the moderators to just briefly, in 1 minute or so, summarize their discussions? I'm happy to start, or Manasvi, would you like to go ahead first? Okay, we will. Thank you. Just to give you a break from all the answering. So we're group 2, and we focused mostly on the question, what barriers exist in sort of facilitating the adaptation of tools from the global south to the global north. Hamra group ma ekdamai, we had a really great discussion. Some of the points that came out were confidence. We're not very confident in sharing, the global south is not very confident in sharing its tools that were developed in the global south to the global north. And it could be because of the way their education was shaped, because of socio-cultural background that might not always facilitate creativity and sharing and confidence. Another interesting thing that came out was that there were a lot of, when ideas come from the global north to the global south, there are also resources that come with it that could be monetary and otherwise. However, the flip is not always true. So there is less incentive for ideas from the global south to be widely circulated in the global north. And our team was very much excited by the presentation because challenges exist, but they're excited by the prospect of this wider arena of global knowledge sharing. We weren't able to talk about the other questions so much, what kind of learnings and experiences can be valuable. However, we did talk about how we learned that tools from the global north cannot be implemented directly in the global south, and that is also true for the flip side, vice versa. So that is all for group 2. Manasvi, please feel free to go ahead, and then we'll do Sauharda and Vinitaji.
Sure, thank you. So for our group, we had a lot of different discussions, but one discussion around how we talk about problems in Nepal and how that can be applied to high-income country settings, so how in ways to reduce stigma. So examples were brought up in how Nepal, even in rural areas, a lot of people now can use the word depression or anxiety and really identify it, but it can be stigmatizing for some people. And in the US, while it's also commonly used, that it can be stigmatizing in some communities as well. But we talked a little bit about how to kind of address those problems without completely shutting out those words as well and stigmatizing further. And then we also talked a little bit about in Nepal, how there's a lot of focus right now on continuously training different communities, different people on task sharing interventions, but the focus should be more on supervision and kind of increasing sustainability. So as we adapt task sharing interventions to high income countries, that the focus shouldn't just be on scaling up and training, but it should also at the same time be on supervision and sustainability to make sure that the task sharing intervention can be long lasting as well and go further than a research trial. And then another key lesson that I think is really important that our group highlighted from Nepal to high-income countries is that that task sharing interventions, but also kind of basic mental health support can be delivered by non-specialists in high-income countries. In the US right now, a lot of mental health is delivered by those with a license to be able to do so. So that that idea of non-specialists being able to deliver care is also really important to bring to high-income countries.
Thank you. Everybody, let's stay on for 5 more minutes because we started a little bit later. I thank everybody for your patience. Soharda, please, your summary.
Thanks, Ritika. I'll make it super quick. And then unfortunately, I forgot to take the notes. So I'll try to remember as much as I can. So one thing that we talked about was a community acceptance. And then maybe like because the health system is very systematic in the US, it might be different. It might be difficult to accept the kind of things that were developed in the global South that might not be as systematic up in there as well. But some of our members in the group, we talked about how it is hard in the US health system, especially with the wait times and the timings and the cost as well. So that might be acceptable as well. And we also talk about the opportunity in the UK where there is a chance of like health system revival or like reimagining the health system up in there and how these things can be brought up there as well. And then regarding the second question, we talked about how things like social support and then peer support can be brought up more in the context of the high-income countries where there is a lot of focus on the biomedical approach and all. So yeah, short and sweet.
Thank you, Soharda. We saved the best for the last. Vinitaji, please, your summary.
Okay, so we have many discussions in our room. So adding to the discussions and summary of Soharda sir, like we have discussed that though the education system of high-income countries is better than low-income countries or middle-income countries like Nepal, but the health professional have more exposure to patients and have more time with the clients so that they can deal with the patients more. Because in social settings, they might have, there are so many of patients and clients who have less knowledge about mental health and mental health related disorders, so that they have to spend more time to make them understand about such conditions, so they would be more connected to each other, which would be important if shared to the high income countries and implemented, because the time management and the time and a good listener can be more better to those patients. And the another questions, we also discussed the second question as well. So in short, the barriers might be the lack of linkage between the health professionals and the researchers between in global South and global North, and also in the countries like Nepal, there are so many field trial, field work, and so many in the form of, but there are very less paper or very less proof that that is written in paper or in written form, so that there might be the barriers for the linkage and flowing of experiences from here to other high-income countries as well. Thank you.
Very interesting discussions in all the groups. Thank you, everybody, so much. Can I request Brandon to quickly wrap up our webinar?
Yeah, I just wanted to thank everyone so much for taking the time. Huge thanks to NIMH, which sponsors this webinar series, and also the mini grants and capacity building workshops that Ritika mentioned at the beginning. I'm so excited to have this exchange learning, and a lot of follow-up meetings will be coming out of this. And biggest thanks to Manaswi for the fantastic presentation, and really just your incredible work bridging everything you've done in Nepal now into New York City. So thanks, everyone. Have a pleasant day or evening, and looking forward to all of our follow-up conversations.
Thank you, everybody. Thank you. Have a great
Thank
rest
you
of
so
the day. Thank you.
Thanks,
Bye-bye.
Thank you. Bye-bye.
Thank you.
Thank you.